everybody out there. I am Dr. Bhavani, Associate Professor of Anaesthesiology, posted in Emergency Medicine. I'm here in Emergency Medicine for the past 3 years, and I'm from Government Stanley Medical College, Chennai. So my topic here was airway management in ER 2024 updates. But 2024 updates was too little, so I took the liberty to take from 2020. And now moving on to the presentation. Emergency airway management involves 3 important factors: oxygenation, ventilation, and airway protection. And airway management becomes a priority if poor respiratory drive is there, if the airway patency is questionable, and if the patient has hypoxia or hypercarbia. So the goals of emergency airway management are to prevent hypoxia, to optimize ventilation, and to secure a definitive airway with first pass when indicated. And now coming to the overview of the presentation. So when I was given this topic, I just went through the online sources and using these keyword searches, and I found a lot of material which I would like to share with you all. And now going to the first part of first topic, checklist. So how is checklist important? As everybody knows, anesthesia and emergency medicine and every, emergency department is very much comparable to airline traffic. So how nowadays we can, of all the modes of transport available, we find airlines to be one of the safest mode. That is mainly because they have a proper protocols for takeoff, for landing, and for while flying, and everything is manned by checklists. So they have done research in their field, and they have found out whenever some fatal event occurred, it was mainly because of a breach in the checklist. So with that, how a checklist
basically
hello. How checklists are important in intensive care. So Erickson et al. In 2023, they have went through reviewed 2046 articles, and they have found out that the outcomes associated with checklists are positive. And in their study, we can see that airway management was included in their study. So importance of checklists in the ED, I see it because of this, because we have a very sick patient, too many people to work, too many equipments, too many unexpected challenges, very little working space, and too little time. So the outcome of airway management can just mean the difference between life and death. So an excellent checklist like this, given by the Difficult Airway Society UK, this one is one wholesome checklist which will help us to be ready with any emergency. So it has got a component for preparing the patient, for preparing the equipment, for preparing the team, and for having alternative plan B and plan C. So this kind of checklist will really improve our practice. Coming to the next part, team and training. So what is the emergency airway management team? So it consists of a team of members who are involved in data collection, patient assessment, preparation of the equipment, hemodynamic stabilization, drug administration, the proper airway management, and the stabilization after instrument stabilization. Another one thing I found in this was a DART, which is called as the Difficult Airway Response Team. So whenever when in ED, we have a duty person to take care of the airway of a sick patient, but then you should have an alternative team called the DART, or the Difficult Airway Response Team, apart from the person posted in ED, so that during any emergencies, they will come and assist. EAM team consists of a team leader who delegate the task, and there will be another person who will be as the operator at the head of the bed intubating, and the nurse will be in charge of the medication, will be standing near the IV axis. The respiratory assistant will help the patient who's going, help the operator who is going to intubate, and somebody else is needed for inline stabilization of cervical spine when the case is a trauma case. So in this Hanna et al., in this ENT journal, head and neck, published in 2023, we can find they have used this Difficult Airway Response Team. And they have found out whenever the team coordinated with the ED team, the outcomes were better. So the ED team consists of the emergency response team and the anesthesiologist, and it is assisted by the ENT and the trauma surgeon. So this DART team is a new thing to me. And then what are skill sets for airway management training? So you should possess clinical knowledge. You should be very active in emergency responsiveness and a little bit of analytical thinking, because you have to think within a small circle and you have to make the appropriate decision, and you should have procedural competency, and you should have some soft skills like communication skills, because you have to talk with your team members, with the family members, with the patient himself, and all these it's done in a very stressful situation, and you should have your own modes of handling that stress. And how are you going to achieve these skills? Practice, practice, and again practice. So the more you practice, the more proficient you become. And you have to continue your CME programs and training programs, and you should have room for constructive criticism. Like you should seek feedback for so that you can improve on the mistakes you have done previously. Now, coming to the airway management proper. So, emergency airway approach can be, put it in a nutshell in an ED, because a person who requires a primary airway management will either have a respiratory distress or no altered sensorium. So, as soon as you see a patient like that in the ED, you initiate the basic airway management like triple maneuver. And as like they say, you have to resuscitate during primary survey, you straight away start with 100% supplemental oxygen. Then you do the look, listen, feel, and you classify the airway into either it is clear and patent, or it is not maintainable. I mean, it is maintainable or not maintainable. So you classify the airway between these three, and if you find any deviation, you try to classify this in this direction also, like whether you have some anatomical difficulty with this airway, or some physiological difficulty, or some logistical difficulty. Anatomical difficulty is some morphological changes in the face. Physiological difficulty is something like when you're doing a CPR, you have to simultaneously manage the airway, and logistical difficulties when you don't have high-end equipments. And now this chart I found very useful, because this chart gives, a single look. You can find out which case will be difficult to intubate, which type of cases will have difficult mask ventilation and supraglottic airway difficulty and surgical airway difficulty. I think this is a keeper, and you can put it up right away in your ED. And coming to the plans, see, first you decide you have to intubate, and then you check the supplies, you assess the difficulties, and straight away go intubate. And in the meantime, don't hesitate to call for help and ensure some sort of oxygen is going. And then when you pre-oxygenate, you optimize the position, and then straight away perform the tracheal intubation. If it is successful, just confirm the placement with the standardized equipment like capnography. Otherwise, you again go for 3 more attempts. So when you go for 3 more attempts, and when you are successful, very happy, you can again confirm the tube. And then if you're not successful, consider rescue oxygenation. You can go back to your mask, or you can use a supraglottic airway device to oxygenate. So even here, see, you have to call for help. You have to ensure some sort of oxygen delivery. And then when you succeed in supraglottic airway placement, and you have to, when the patient is okay and fine, you have to maintain the airway and go for an invasive access. So this does difficult airway guidelines, difficult airway society guidelines from UK, which was published in 2015, is holding good up to 2022. It says if the laryngoscopy fails, go for the supraglottic airway device, and again go back to mask ventilation. And if you're not able to maintain, call it CICO, or the cannot intubate, cannot oxygenate scenario, which is really a tough situation. And when you come to this situation, like you cannot intubate and you cannot oxygenate, the only access we have is the front of neck access, where you do a surgical cricothyroidectomy, and you place a definitive airway right inside the cricothyroid membrane to oxygenate the lungs. So here, when you, sometimes when you are able to revive the patient after the rescue oxygenation, you have some time for performing placement of a definitive airway. If you have some time in between that failed intubation and for another procedure, you can go for awake tracheal intubation. So you oxygenate the patient and you topicalize with anesthetic spray to anesthetize the airway, and oxymetazoline sprays for the as to be used as a vasoconstrictors for the nasal mucosa, and to decrease the secretions, you can use atropine and glycopyrrolate. So topicalize and then give some drugs and perform the ventricular intubation. And once the tube is definitely placed, you can sedate the patient. And now, see, why this emergency airway management is like a whirlpool. If you can settle with the mask, it's okay. If you can settle with a supraglottic device, it's so fine. When you can put in a tube, it is super fine. But then, not the same thing doesn't happen for every patient. So whenever you find yourself in an unanticipated, difficult airway situation, always be very sure to do be sure to of what you are doing, and then please don't hesitate to surgical airway. Under these recommendations from 2024 for pediatric airway, they say that we have to assess the airway before planning our intubation. So you don't hesitate to sedate and don't hesitate to use a neuromuscular blockade. And laryngoscope is recommended as the first attempt itself. And apneic oxygenation is also suggested. And supraglottic airway also goes in for even for children and babies. So here you can see this slide assessment of emergency assessment of the airway of a child. See, can the philtrum, straight line is drawn from the philtrum, but then there is actually this philtrum should be aligning with the chin. When the line drawn from the philtrum is not aligning with the chin and you have a gap in between, this is micronathia, there will be very low working space when you put the laryngoscope, and even if you see the glottis, you won't be able to put in the tube because there won't be any working space at all. So this is a case of difficult airway which you have to assess at the first look. And now coming to the positioning, everybody knows the classic sniffing position in adults. So what is that? Actually, there are two lines. One line is from the glabella to the chin, which should be horizontal. The next line should be from the external auditory meatus to the suprasternal notch. So how are we going to achieve these two lines become horizontally aligned? This is done by flexion at the lower cervical vertebra and extension at the atlanto-occipital joint. So this is what we are trying to achieve when we are positioning the patient for intubation. So this is simply achieved by keeping a pillow under the occiput. The pillow should be 10 centimeter height and it should be a non-compressible pillow. It's commonly called as Poppet's pillow. So when you use a pillow right behind the occiput, you can achieve this flexion at the neck and the extension at the atlanto-occipital joint. You can see here that the external auditory meatus and the suprasternal are in line here. And then if the patient is obese and he has got a lot of fat deposition in the torso, it will not be able to align the suprasternal notch with the external auditory meatus. Then you do something called as ramping. Ramping is either done by placing sheets and pillows beneath the torso, or you just give a head, the head end of the bed is lifted up. This ramping is also done to achieve the same procedure, the same line of alignment. The external auditory meatus and the sternal notch should be in position. And this is a new position I saw in the literature search that is called as Hassanin pillow, the modified ramp position, where they have a pillow with two curves. And then the shoulders are elevated and the head has extended to the most possible range to bring the breast away from the laryngoscope so that the maneuvering of the laryngoscope will be possible without hitching the breast. But then this is not possible in trauma. And out of the hospital setup, when you are transporting the patient, you can use the stretcher to get the head elevated to intubate to achieve this position. So positioning, you either lift the head or you lift the bed. And now in the study in 2023, we find that obesity was associated with the lower first pass success of intubation, but it was improved with the utilization of a ramp position. So the ramping is still going good in 2023. In adolescent, again, the same rules follow. You should have an open neck, the glabella chin, and the external auditory meatus and the sternal notch should be aligned like this. But in the baby's head is large and they cannot hold in a straight place. So what happens is flexion of the head occurs. This flexion can go and obstruct the airway. So just by keeping a roll of towel under the shoulders, you can achieve this mild extension. With this, you can give some little bit jaw thrust and head tilt, and then when try to oxygenate the child. And some children, a mere head extension will cause this to align. but certain children may not align as such. So what you do is first you place a roll under the shoulder and check whether both are aligning. If not, again add one behind the head so that finally the glabellar chin line and the external auditory suprasternal notch line gets aligned. And then you can also keep a roll like this. You roll both sides and put the large head in between the rolls. And you can also have an assistant to hold the head like this when you are intubating. Not only for the patient, the operator too needs to bind his position, because when he is behind the headrest and the patient is down below, it's very difficult for him to look at the glottis. So what you do is you push take off the headrest, push the patient near your, so that he's get aligning with your umbilicus. Otherwise, when the headrest cannot be removed, as like in many government hospitals like us, what we do is we put the patient in a standing position so that head just comes to this part of the edge of the bed, and we again achieve this position. And how you stand and how you hold things are also important. For example, see here, when this person is trying to put that bougie and he's keeping his arms abducted. And then you can see the edge, tip of the bougie is not at all going to the glottis. At the same time, when he adducts his arm, it straight away goes to the glottis. So the position of the patient and the operator is very important. Not only that, the whole thing needs to be positioned as per plan. Now coming to pre-oxygenation. So pre-oxygen, see, all these are references I got from the literature search I did. I just mentioning the points to you. Now, pre-oxygenation is a vital part of emergency airway management in any setting. But first, we have to understand the physiology. So what happens? See, this is the graph between the alveolar ventilation and alveolar saturation. Okay, so now here the alveolar ventilation, when the patient is breathing room air, you can see to achieve 100 millimeters of mercury of oxygen saturation, almost you need 3 to 4 liters of oxygen. Okay, but then when the patient is breathing enhanced FiO2, increase inspired oxygen of 0.5, then even less than 1 liter is sufficient to bring about this alveolar saturation. So much is important. So much is pre-oxygenation important. So in all airway plans, kindly mind this point. Please keep some form of oxygen going to the patient. And now how to optimize pre-oxygenation in the ED. First point is to get a tight seal of the mask while pre-oxygenating. Here you can see in the bed and in the pre-hospital care also, you can see the routine EC technique is being done. And then the size of the mask should cover the nose and the mouth, and it should never come to the eyes, because if there will be a leak here. And then in 2022, in the Indian Journal of Anaesthesiology, Apneic et al. Have found out, have mentioned about this modified thenar eminence technique and the conventional thenar eminence technique for mask ventilation during induction of general anesthesia. This is just to have a tight seal. See, for example, when you hold like this, the fingers are holding on to the mask and the face. But then when you look at this picture, you can see the whole thenar eminence is used to hold the face to the mask. So this is the difference, and they have found out that this technique of thenar eminence holding is very good. And these are the various in the publication published in 2022 in the Journal of Pre-Hospital Care. They have found a few techniques, so which I thought I should share with you. So this is the first routine EC grip. And this is the EO group, wherein we are a small female holding on to a big male's face cannot cover this part of the face with a C. So to encircle the other side of the mask, they have this EO grip. And then you have this two-handed EC grip and this two-handed thenar grip. So next time you are trying to mask ventilate a patient, please remember this. And how to optimize pre-oxygenation in another way to increase FiO2. See here, there are two ways of oxygenating this patient, one with the mask and one with the nasal cannula. And they say a cut off ET tube like this, fix it to an adapter, connected to an oxygen source, can as a mouthpiece also, then by giving many sources of oxygen will finally increase the FiO2, because nasal cannula alone or the NR mask alone cannot give 100% oxygen. And so for giving this putting these two devices into a single flow meter is very difficult. So many recommendations were there for dual flow meter, the bifurcated oxygen flow meter. In more oxygen being delivered, and when you're putting a patient on a nasal came across. 2 days of oxygenation. Here you can see the patient has got a HFNC cannula and also a Hudson mask. And here also you can see the patient has got a simple mask. Here HFNC, and here he has got that mouthpiece too. So the idea is to increase the FiO2 of during pre-oxygenation, you have to have one or more devices over the patient so that the true purpose of pre-oxygenation will be served. And then how to optimize again. So when the pre-oxygenation is done in a 20-degree head-up position, as found out by Hung et al. From Malaysia University in December 2022, they found out that 380 seconds in head-up of oxygen, but in supine position it's what 283, almost 100 seconds you have extra if you are going to pre-oxygenate in a head-up position. And also even in trauma you can do this by giving a reverse render on the position so that the whole of the bed is, head side of the bed is elevated. And then the third way to optimize pre-oxygenation is to give flush rate pre-oxygenation with an NRM mask. What is this flush rate pre-oxygenation? See, in the conventional flow meter, normally you have 15 liters marking. But then if you open the knob beyond the 15 liters, some around 40 to 60 liters will be delivered and you will hear a hissing sound. I think everybody would have encountered that. So that is called as flush rate oxygen. So when you are pre-oxygenating in that part of airway management, they suggest that we give flush rate pre-oxygenation. See, in these two studies, one inside the theater and one in the pre-hospital setting, both papers in 2022 and 2023 have convincing evidence that the flush rate oxygenation is very good. And then now we know how to pre-oxygenate, how much to pre-oxygenate. So you have to deliver at least 100% oxygen. That is why you use one or more devices. And in the fresh gas flow mode, should be more than 10 liters per minute so that it exceeds the minute ventilation of the patient. And also the peak inspiratory flow is at the higher levels to eliminate the rebreathing. And then the breathing pattern during pre-oxygenation, you can ask him to have 8 vital capacity breaths or 3 minutes of tidal breaths in 1 minute. So either way you can do it. And now, do you have to monitor the pre-oxygenation? Definitely yes. You have to monitor via capnography. At the same time, you have to use an oxygen analyzer too to see to that the fraction of expired oxygen is more than 90%. So that is why we need to give 100% oxygen while pre-oxygenating. And now, if you use an NRM mask at 15 liters per minute, the end tidal oxygen levels are 54. With a flush rate, it is increasing up to 86. In a BVM device at 15 liters, it's 77. And with a simple mask, if you give a flush rate, you can achieve this. So please remember to use flush rate whenever you want to pre-oxygenate. And now in this hallmark article by Scott Weingart and Rich Levitan, they say it is impossible to predict the exact duration of safe apnea. But then when you have high saturation levels on room air or after oxygen saturation, you have 8 minutes before desaturation. So this time is truly needed. Now coming to apneic oxygenation. So what is apneic oxygenation? So you pre-oxygenate the patient and after some time you cut off the oxygen and you're doing your laryngoscopy. In that the saturation will maintain for a certain period, that is called the safe apnea time. After that the saturation will fall down. So this during this period when the patient is not breathing, when you give oxygenation, that is called as apneic oxygenation. How are we going to give this? See, the intubating tool itself has got ways of apneic oxygenation. Especially this is very important for in pediatrics because of decreased FRC where desaturation happens so fast in a child. So the Miller's blade, certain versions will have apneic oxygenating port too. And then here you can see the HFNC cannula is used for apneic oxygenation. So it is lying here over the nose while the operator is intubating. And here they use a nasal cannula to connect it to the oxygen source, and they will remove the dural airway and they will intubate through this. And also the newer radio laryngoscopes also, they have channels for oxygenation for apneic to provide apneic oxygenation. So is apneic oxygenation as good as pre-oxygenation? But they say it is very important for the pediatrics. But then few studies like this one by Fuchs et al. In British Journal of Anesthesia in 2024, very recent study, they have found out the oxidative stress like bronchopulmonary dysplasia and severe retinopathy prematurity is on the increase when you are trying to maintain hyperoxia even for a very short period. So you have to think twice before doing this. So now resuscitate before intubation. What is PICA? PICA is peri-intubation cardiac arrest, and I bet everybody over here would have encountered this situation. So this is mainly due to unstabilized hemodynamics at the time of intubation. So in 2020, Maine Medical Center Winter Symposium, they found out, they published that the shock index, if it is less than 0.9, then it is good for the time to intubate. And if there is time, first resuscitate. So if there is only hypovolemia, just give fluids. If there is blood loss, give blood. And if you cannot give both, use a pressor efficient, but somehow try to maintain the systolic BP above 90. And when you're using drugs, always use at a lower level because ketamine, midazolam, propofol, every drug in that armamentarium can cause hypotension. So now coming to the drugs per se. So when you're trying to induce a person with a head injury, try etomidate. When the patient has got some cardiac problem, pulmonary edema, try etomidate. But when the patient is in shock or has got a restrictive airway device with a wheeze, go for ketamine. And seizure stopping characteristics of propofol will help in those who are having a status epilepticus. Now, I think succinylcholine is long gone from my department, anesthesiology. But then in 2024, there is strong evidence. This is, like a systematic review and randomized control trial, very valid studies. They say that succinylcholine is very much useful in the ED because of rapidity of its onset and in providing consistent intubating conditions. And then once you give 1.5 milligram per kilogram of succinylcholine, even the onset of action is between 45 to 60 seconds, and it stays up to 6 to 10 minutes. And when you want to give succinylcholine, always give the required dose. Don't cut short the dose because inadequately paralyzed patient is more difficult to intubate. And also, this study says that succinylcholine, though it is recommended for pediatric emergency intubations, has not been approved by the FDA for elective surgeries. Now, there are so many contraindications for succinylcholine, but then this too have been in the backside of my head during my practice. So in renal failure, unless there is significant hyperkalemia suggested by characteristic changes in the electrocardiogram, you can still give succinylcholine. And in the same way, in a traumatic case where there's eye globe injury, where succinylcholine is supposed to increase the intraocular pressure, that increase in the intraocular pressure is obtained by the induction agent, so indication. Rocuronium, so there are many centers who strictly follow rocuronium, fearing malignant hyperthermia, medical legal implications of succinylcholine. But then most of the studies say when succinylcholine is contraindicated or prolonged neuromuscular blockage period, that is only when rocuronium is used in their setup. And also we need costly reversal agents to reverse if there is any residual blockage. So for emergency airway settlement, I think succinylcholine is the best drug. And there's something we need to know about the rapid sequence intubation and the delayed sequence intubation. Rapid sequence intubation, you pre-oxygenate, give ketamine, you give succinylcholine and you intubate. But then in delayed sequence intubation, you first give ketamine, then pre-oxygenate. So why did this delayed sequence intubation come into vogue? See, when some patients delirious due to trauma or decreased cerebral hyperperfusion is there, so then the patient will be irritable and they cannot hold on to the mask. So in such situations, you first give small incremental doses of ketamine and calm the patient, and then you pre-oxygenate, and then you give the paralyzer, and then you intubate. So pre-oxygenation is so important that a different technique itself has been brought into vogue. So when you, the first pass success of a endotracheal tube depends on robust pre-oxygenation, correct dosages and timing of the medications, and use of a video laryngoscope. So for all the juniors over here, please concentrate on these three. And the delayed sequence intubation appears promising in critically injured trauma patients who do not allow adequate pre-oxygenation due to agitation and delirium. See, you want to intubate a trauma patient, you cannot cause him PICA, peri-intubation cardiac arrest, because you cannot pre-oxygenate. So you need not worry about that. Go for delayed sequence intubation. So what are the badges for airway management available? See, we all have this bag valve mask for oxygenating the patient, but then how many of us have a PEEP valve? So the recent recommendations say the BVM mask, bag should contain a PEEP valve. So the PEEP valve should be set at 5 to 15 centimeters of water to improve oxygenation prior to intubation. And PEEP of more than 20 centimeters can cause gastric insufflation. So you need to monitor this PEEP, and you have to have a PEEP valve. Next is you attach a manometer, pressure manometer in the ambu bag, because it is a ISO standard for pediatric ambu bag. So whenever you are ventilating a child, please use an ambu bag with a pressure manometer. And here you can also minimize the aerosol spread by attaching a viral filter. Yellow color goes for the adult bag and the blue color goes for the pediatric. You can attach a nebulizer adapter and nebulize through a bag. Drugs like adrenaline and normal saline can be given when you have airway edema. And then always have some monitor to monitor the end tidal carbon dioxide, because you should be very sure of how much you are giving and how much you are taking out. So always have a end tidal carbon dioxide monitor. So this is how now your ambu bag should look. So it should have a appropriate mask. It adjuncts like oropharyngeal and nasopharyngeal airways should be coupled with them, and it should have a manometer. It should be a volume limited bag. Don't go for a high volume pumps, and then we should have a PEEP valve. And then CPAP and BiPAP. Now we can see these are for medical cases. See, when you have a patient with type 1 respiratory failure, say like pulmonary edema who comes with hypoxia, you put him on CPAP. But then when you have a COPD patient with type 2 respiratory failure, hypoxia and hypercapnia, BiPAP is better. And you have got various CPAP interfaces with the helmet CPAP also coming. And now when you have an acute medical emergency in an ER requiring intubation, see, you first put him on NIV, and then if he's improving, just leave him alone, continue NIV. If he's not improving, put him on a tube. But if the patient is uncooperative, put him on a tube straight away, paralyze him, sedate him, and while you're weaning, put him on NIV. So NIV has got so many roles in the medical side of the ER. And another one thing, the high flow nasal cannula. Here in theaters, we use this for pre-oxygenation. It's a very useful tool, and it makes the anesthesiologist or the patient, person who is trying to intubate hands free, because you can just put the cannula and then you can do other jobs. And also in because in the CPAP, they have a closed mask. The incidence of ventilator-associated pneumonia is more, but then that is not with NIV. So that is also found in one study. HFNC you can use in pre-hospital transport, in the patient bedside. And now coming to the other gadget, so ultrasonogram. So how is ultrasonograms useful in ED, in airway management? So you have got methods to assess the difficulty in airway management. There are 4 views: thyrohyoid view, suprahyoid neutral view, suprahyoid extended view, and suprahyoid ramped view. So you have this chart, and then if you find any positive factor in this, you can brand them as difficult airway. So this is a very useful tool. And if when you see an endobronchial intubation, like one side the lung is ventilated, the other side is not ventilated, asymmetrical barcode sign can be seen. And here double tract or double trachea seen. When the tube is in the esophagus, you can see 2 trachea-like things. So that is called as double tract. So this helps in ruling out esophageal intubation. And to see whether you have placed fixed the tube properly so that both the sides and all the zones of the lungs are getting ventilated, you can place the probe and see all the zones are, you're getting the lung sliding in all the areas. And then you can use the ultrasonogram to find out the tube placement again. And now it can be used to identify the cricothyroid membrane also. See, first you place the probe in the thyroid cartilage, okay? So you will get a straight line view like this of the thyroid cartilage. Then you go below, you get this cricothyroid membrane view. And then you go below and then you get this C-shaped cricoid cartilage view. And again you go back up. So you, from the thyroid cartilage, you go down to find the membrane, still go further to find the cartilage, then you go up again to find the membrane. So this is one way of identifying. Now, what happens when you have a soiled airway? This is very common in trauma. So they say this airway recommendation by James D. Contow says suction-assisted laryngoscopy, laryngoscopic airway decontamination called the salad technique. See, what happens is you put in a video laryngoscope. You have a rigid Yonker catheter. So instead of the flexible suction catheter, and then you put on the right side of the mouth, put the catheter right side, and then you introduce the video laryngoscope, and then you take the suction tube and put on the left side, and next step is put the endotracheal tube on the right side. So this is a very important technique. So when you see the videos available in the net, it is so useful. Like so many cases we get trauma here, and if I had known this before, I would have done that. And bougie is a very, humble adjunct we have in our wards. But then in 9,000 adult patients, in a systematic review and meta-analysis of 18 studies, they say regardless of the method of intubation, whether it is direct or video laryngoscopy, bougie is very important. And then it can be used to intubate anywhere also. And then it also in difficult airway situations with Karma-Kehan score more than 3 also, they are very effective. So always try to have a bougie at hand. So this video I would like to share with how they are introducing this at right angle, introducing the bougie at right angles. So they are putting the laryngoscope like this, and then he's introducing the bougie at right angles. So it goes inside, and now the operator himself holds the bougie with his one hand, and then introduces the tube through the other. So this is a mode of intubating with the bougie. And then this is folding on itself. This is already known method. And then we have another one in the market. This is called as an articulating bougie. This has got a gun-like piston here and a flexible tip. So you can use this gun to move this tip up and down so that it enters the glottis. And coming to the supraglottic devices, we have the LMAC track and the video laryngoscope SACO video laryngeal mask, which has got a pressure monitor. The oropharyngeal laryngeal pressure monitor is there so that we can comment on the amount of pressure seal it gives when you introduce it. And you have got this LMA Supreme with the curvature and the cuff. And this is the Baska LMA. It is a combination of iGel. It does not have a cuff, but it has got a very big gastric port. So based upon the principle of thermoplasticity, whenever this is introduced into the mouth, depending upon the thermal principles of the musculature present in the pharynx, it gets aligned and gets a proper seal. And then this one study was interesting because they have used a blockbuster LMA and fast track LMA for doing blind endotracheal intubation. So blind endotracheal intubation, certainly with once or twice we would have to do in the ED. Maybe we should think of using a blockbuster LMA or a fast track LMA for that. We have the cheaper version of the fiber optic laryngoscope called the ambuscope. And here, this technique is also a learner point. See, they're using a video laryngoscope and a flexible fiber optic scope to intubate. So you can use two devices to oxygenate. You can use two devices to intubate. So everything is possible. And then you have the video laryngoscope here. And which laryngoscope to buy? So you have a mat blade, you have a standard geometric angulated blade, and you have a hyperangulated blade. So when you have a normal mat blade, you have to see through the mouth, the glottis. When you have a standard geometric curve, you can see through the mouth and you can see through the video also. But then when you have a hyperangulated blade, you can see only the video. You cannot see inside the mouth. So whenever you are using a hyperangulated video laryngoscope, you have to put a stillet into the endotracheal. And now, so video laryngoscope, a lot of them are in the market. Should we end buying direct laryngoscopy? Definitely, there is advantage of video laryngoscope, but we have certain indications for direct laryngoscopy also. And now coming to the surgical cricothyroidotomy, the National Emergency Airway Registry is a very important study of 17,000 adult intubations were done, and out of which 25 patients plus 55 patients needed surgical airway, which means that this is a significant number. So as trainees, we should be trained in that. So this, what you need a scalpel bougie technique is a endotracheal tube, a bougie and a scalpel. You identify the cricothyroid membrane, you put a vertical incision, you give a horizontal stab over the cricothyroid membrane, and then you turn it 90 degrees so that a hole is created in the membrane through which you introduce the bougie, over which you thread the tube, and then you check with your capnograph. So that is how you do a surgical cricothyroidotomy. That takes less than 90 minutes. So how are you going to monitor the adequacy of ventilation once you have intervened the airway? So visible chest rise, oxygen saturation, exhaled carbon dioxide levels, heart rate, blood pressure, distal air entry, patient response. So these were the indicators to monitor the adequacy of ventilation in many of the studies. And why I'm talking so much? Why I'm talking so much about intubation? See, I took up two studies, one in 2011 and another one in 2021. See, the risk of injuries due to intubation is on the rise. It is not coming down in spite of so many training programs, so many mannequins, so much of knowledge about intubation. So intubation is still a game player that decides the life and death of a patient. While doing this literature search, I found that few conflicts were there, because in the Society of Critical Care Medicine clinical practice guidelines, they don't mention anything about video laryngoscopy. But then in next year itself, in 2024, the using statements is whole lot on video laryngoscopy. I think we have to read more to find out which is better for what. And the recent advances of artificial intelligence, there are so many things to predict the difficult airway and all that. And we have to go a long way for this. And what are the take-home messages? So have checklists. So prepare checklists complying with your institutional practice. But be liberal to individualize to each patient when you actually use them. And be prepared for the usual and unexpected by knowing about plan A, plan B, plan C, and plan D. Team up and train periodically. Oxygenation is the key to safe airway management. You do it during pre-oxygenation, during apneic oxygenation, during rescue oxygenation. So capnography in oxygen analyzer becomes minimum mandatory monitors next only to non-invasive BP monitor, ECG, and pulse oximeter. So when you have money, invest in bougies, bag valve mask, accessories, video laryngoscopes, dual flow meters, and ultrasound machine. Surgical airway needs a training boost. As with assessing airway, always try to assess yourself for the recent updates. Thank you.